Welcome to this explainer. Today, we're going to do something pretty incredible. We are going to decode the microscopic war happening right now inside human bones. You know, when we think of bone, we usually imagine this totally static, lifeless scaffolding, right? But the reality is actually wild. Your skeleton is a highly active, totally ruthless cellular battlefield. So by the end of this explainer, you're going to understand exactly how this invisible war is fought, lost, and ultimately won.
Okay, let's dive into this. Here is our flight path for today. We'll be covering the silent bone thief, the cellular battlefield, measuring your fracture risk, the medical arsenal, and finally, the hidden dangers and complications.
Section 1. The Silent Bone Thief.
Right off the bat, we need to completely shift our perception of osteoporosis. It is definitely not just some harmless condition where people simply get a little shorter as they age. It's actually a massive, incredibly costly medical crisis. To really put the gravity of this into perspective, just think about this. In the United States alone, there are around 300,000 hip fractures every single year, and the mortality rate, it's shocking. Between 20 and 25% of patients will literally die in the year following a hip fracture. And that mortality rate is even higher for men and African Americans. Plus, the financial toll of all these fractures is just staggering, costing the healthcare system roughly $19 billion annually. So this isn't just about aging. It is absolutely about survival.
Now, clinically, we define the disease based on bone mineral density using a T-score, which we'll explain a bit more shortly. But basically, a score of -2.5 or below is official osteoporosis. But here is the truly surprising fact. Over 50% of all fractures actually occur in the osteopenia range. That's between -1.0 and -2.5. You might be wondering, why? Well, simply because that population is so massive. Roughly 40 million Americans have osteopenia. So the sheer volume of people with just slightly thin bones means the absolute number of fractures is astronomical.
Section 2. The Cellular Battlefield.
To really understand how we lose this bone, we have to look at it like a microscopic construction site. Your bone comes in two main types. The dense outer shell is cortical bone, and that makes up 20% of the surface. But 80% of your bone's surface is trabecular bone. That's the spongy, honeycomb-like structure inside your vertebrae and your hips. Because there is just so much surface area here, this trabecular bone is the primary battleground. It's where all the metabolic action happens, making it the very earliest casualty of bone loss. And that is exactly why vertebral spinal fractures are often the very first clinical sign of the disease.
Out on this battleground, there are two opposing crews constantly at work. You've got the bone builders, called osteoblasts, and the demolition crew, called osteoclasts, and the communication between them relies on two main signals. First is rank L. Think of rank L as the demolition signal. It basically activates the osteoclasts to tear down bone. On the other side, we have OPG. Now, OPG acts as a decoy receptor secreted by the builders. It binds to rank L, neutralizes it, and completely protects the bone. So your overall bone density entirely depends on the delicate balance between rank L and OPG.
So what happens when things go wrong? Let's walk through the exact cascade that triggers postmenopausal bone loss. Normally, estrogen keeps that demolition crew in check. But when estrogen levels drop after menopause, three massive things happen. First, rank L skyrockets while OPG drops, which just floods the site with demolition signals. Second, the lifespan of the builders, the osteoblasts, completely plummets. And third, immune signaling molecules, specifically pro-inflammatory cytokines like IL-1 and IL-6, spike, making the demolition crews hyperactive. It's a catastrophic, total victory for bone resorption.
Section 3. Measuring your fracture risk.
Now, since this cellular war is totally invisible, the medical field has to act as a reconnaissance unit, using DXA scans to spot the damage. Now, what's really interesting about this slide is how we actually interpret those scans. We generate two distinct scores. The T-score compares your bone density to a healthy, young, 30-year-old adult. This is the score we use to actually diagnose osteoporosis and make our treatment decisions. On the flip side, the Z-score compares you to age-matched peers. If your Z-score is unusually low, it's a huge red flag that tells your doctor to look for secondary underlying diseases causing the bone loss, not just normal aging.
But bone density isn't the whole story, right? Doctors also use the FRAX score calculator. This factors in your age, weight, smoking habits, and steroid use to predict your 10-year fracture probability. In the US, the exact thresholds to deploy medical reinforcements are very clear. If your FRAX score shows a 20% or higher chance of a major osteoporotic fracture, or just a 3% or higher chance of a hip fracture in the next 10 years, it is absolutely time to intervene.
Section 4. The medical arsenal.
When that fracture threshold is finally crossed, we don't just rely on calcium and vitamin D anymore, we bring in some serious pharmacological tactical weapons. And these weapons basically fall into two fundamental strategies. Anti-resorptive drugs are defensive. They actively block, disable, or even kill the osteoclast demolition crews, which allows your natural builders to slowly fill in the gaps. Anabolic drugs, on the other hand, go straight on the offensive. They actively stimulate the osteoblast builders to lay down brand new bone, increasing connectivity and cortical width.
Let's look at the heavy hitters in our medical arsenal. Bisphosphonates, like alendronate, are your standard anti-resorptives. Then you have zoledronic acid, which is heavily utilized for its sheer convenience. It's actually given as a single IV infusion just once a year. Pretty amazing, right? Then there is denosumab, a biologic injection that uniquely has no plateau in bone density gains. But the most fascinating one has to be romosozumab. It possesses this incredible dual-action superpower. It blocks the demolition crews and forces the builders to construct new bone at the exact same time. Because of its massive potency, the FDA strictly limits its use to just 12 months.
Now, when you compare these drugs to a placebo, their sheer efficacy in preventing spinal fractures is just staggering. Alendronate cuts spinal fractures by 50%. Teriparatide, which is a potent anabolic builder, based on parathyroid hormone, reduces them by an impressive 65%. And that once-yearly zoledronic acid IV infusion, it reduces vertebral fractures by a staggering 70%.
So, the crucial point is this. While these drugs are incredibly powerful, they require some very careful strategy. And this is especially true for denosumab. In the medical world, we actually call it the denosumab trap. If you simply stop taking this injection, you don't just return to your baseline. No, you experience a massive, rapid rebound in bone turnover, severe bone loss, and a really high risk of multiple sudden spinal fractures. You can literally never simply stop it. You must carefully transition to a bisphosphonate to lock in those hard-earned gains.
And that strict rule brings up a pretty startling question, doesn't it? What happens when the cure actually causes a break? It's a total paradox, and it pivots us toward the counterintuitive risks of radically altering bone metabolism for years on end.
And this brilliantly illustrates our final section, Section 5, Hidden Dangers and Complications.
In every cellular war, deploying heavy artillery for too long always risks some friendly fire. Long-term use of anti-resorptives carries rare but very serious risks. One of them is MRONJ, which is an incredibly painful necrosis of the jawbone, usually triggered by invasive dental work while you're on the medication. Another major one is the atypical femoral fracture. By freezing bone turnover for 5 to 7 years, microdamage essentially accumulates until the femur just snaps horizontally. This is absolutely crucial. If a patient on long-term bisphosphonates complains of an unexplained aching thigh or groin pain, you must check both femurs immediately, because about 50% of these fractures end up happening bilaterally.
Speaking of medications, we can't ignore the collateral damage from other treatments. Glucocorticoids, or steroids, are actually the most common medication-induced cause of osteoporosis. They act as rapid destroyers. They basically paralyze the bone builders and accelerate the demolition crews. And the truly terrifying fact here is that severe trabecular bone loss and clinical fractures can happen within the very first 3 months of starting steroid therapy.
As we wrap up this explainer, we really have to return to the most insidious characteristic of this entire disease: its silence. A shocking 70% of vertebral compression fractures present with absolutely no sudden back pain. They are completely asymptomatic, save for maybe a gradual loss in height. So I want to leave you with this provocative thought. If 70% of spinal fractures make no sound at all, what microscopic battles might be quietly raging inside your own skeletal system right now?